When we think about the sort of help that the health and care system offers, we might very crudely characterise it into two broad types: fixing people and helping people. In the Fix Me domain, the system tackles issues that are primarily medical in nature, most obviously things like cuts and broken bones, but also many other forms of illness. By contrast, helping people often means addressing issues that are primarily psychosocial in nature, such as loneliness or support to wash, dress, or prepare a meal. These two domains can be seen writ large in the historic separation between health and social care services, even though there is broad acknowledgement that many of the problems citizens face in their lives will need coordinated effort to both help and fix them. Also notable in the historic design of the system is that whilst healthcare is universal and free at the point of use, social care is subject to eligibility criteria based on the nature and severity of need. For example, continuing healthcare criteria are used to manage the boundary between what health services should pay for and where social care or the citizen themselves should pick up the tab. Similarly, fair access to care standards provides an eligibility framework which supports social care services to determine the level of their response, according to whether need is low, moderate, substantial, or critical. Typically, social services departments have set their thresholds at critical and substantial, meaning that those with low and moderate needs have to go elsewhere for help. In fact, when we take a macro view of the health and care system, we can see that these concepts, that need is broadly medical or psychosocial, and that it is low or simple through to high or complex, have created the frame in which much of the historic health and care system has been designed, commissioned, regulated and funded. It is this same frame which has tended to shape budgets, what gets measured, and also, perhaps by consequence, what gets managed. It is this frame too which explains in large part the presence of significant levels of failure demand in the system, and the ongoing difficulty which the system's leadership has in addressing its root causes. Take for instance an individual with relatively low but increasing need of help. Such an individual does not qualify for the help of social care, rebounding from their eligibility criteria and commonly accessing their GP instead. However, what is a GP to do? Whilst the third sector may offer a huge range of genuinely helpful support, too often it's hard to know what is out there and how to access it. In fact, when the lives of many high dependency users of health and social care are looked at in the round, a common dynamic can be seen. Frequently, such individuals will have accessed their GP, failed to find help with their psychosocial issues, and will then have escalated through the Fix Me system to end up in hospital and or repeatedly bouncing off the eligibility criteria of social services. Looked at from this macro perspective, the lives of those citizens who are most in need of help from the system can be seen to be characterised by the repeated churn in and out of services, which are configured primarily to fix them, and which are therefore not set up to provide the help that they need. For citizens, the consequences of working this way are frustration, anxiety, and a life of increasing dependency in services. Meanwhile, for the system, there is all of the associated cost, coupled to the frustration of working with partners and colleagues, where commonplace good intentions are frustrated by the competing priorities, policies, and perspectives created by the two axes of need.